Thank you for the opportunity to present here today. These are our disclosures. Gastroesophageal reflux disease is a chronic condition that affects up to 0.25% of the population and results from a defective lower esophageal sphincter. The chronic assault of the refluxid on the esophagus causes progressive damage to the esophagus, such that some patients present with severe symptoms in a positive pH study, but a fairly normal esophagus. These patients have uncomplicated disease. However, as the damage to the esophagus continues, patients can develop erosive esophagitis and Barrett's, or complicated disease. Large hiatal hernias are often associated with complicated disease. PPIs are the standard medical therapy. However, up to 60% of patients will continue to have symptoms despite optimal therapy. But less than 1% of these patients will undergo a laparoscopic Nissen fundoplication, which is the gold standard surgical treatment. This is mainly due to concerns over undesirable side effects such as gas bloat syndrome and dysphagia and durability. Therefore, it is mainly patients with complicated disease who accept these side effects and undergo fundoplication. Magnetic sphincter augmentation was specifically designed to address this gap population of patients with uncomplicated disease who continue to have symptoms despite PPI therapy. It's a flexible band of interlinked magnetic titanium beads that's placed at the GE junction and augments a weak lower esophageal sphincter, preventing reflux while still allowing normal functions such as swallowing and belching. Multiple studies to date have shown MSA to be safe and effective, with PPI elimination and pH normalization rates comparable to fundoplication. Initial studies have excluded patients with complicated disease. However, since FDA approval in 2012, some providers have begun using MSA in this patient population. When we look at the results of the studies to date, we see a persistent failure rate defined by PPI use of 15 to 20%. So the aim of our study was to identify preoperative variables that are associated with MSA failure so that we can choose which patients would benefit from MSA and which should be referred for fundoplication. Our hypothesis was that since MSA was developed for uncomplicated disease, that patients with more complicated disease would be more likely to fail MSA. This was a retrospective study of all patients undergoing MSA at 3 institutions over an 8-year period. GERD HRQL scores were performed at each follow-up, and more invasive testing such as esophagram, EGD, and pH studies were done at the surgeon's discretion and based on symptoms. Failure was defined as daily PPI use, esophagitis of any grade, or a positive pH study. We identified 286 patients who underwent MSA and had at least one follow-up. The mean follow-up was about 9 months, and out of those patients, 84 had a postoperative EGD at a mean follow-up of 13 months. We identified a failure rate of 13.6%, which is consistent with what has previously been reported in the literature. Of that, 35 patients had daily PPI use, 17 had positive pH studies, and 7 had esophagitis. When we looked at our two cohorts, those who failed MSA and those who did not, we found no difference in basic demographic data such as gender and age. We did see a trend towards a higher incidence of obesity in the failure group. However, this did not reach statistical significance and could be related to the power of our study. We did not see any difference in any of the other preoperative variables we looked at, such as pre-op GERD HRQL scores and the Meester score. We looked at supine reflux as a marker for a more defective lower esophageal sphincter. And for the 136 patients for which this data was available, we again did not see any difference in the two groups. Also, when we looked at Barrett's esophagus and esophagitis, which are markers for more complicated disease, again, we did not see a higher incidence of these in the failure group. Surprisingly, we also did not see a higher incidence of large hiatal hernias in the failure group. There were 7 devices that were explanted, 1 for gastroparesis and 6 for persistent GERD or esophageal pain. There were no erosions. We did identify 5 patients in the failure group who were found to have the MSA device placed on the proximal stomach. All of these patients were symptomatic, and they all had positive pH studies. So, in conclusion, MSA failure was not associated with complicated or advanced disease or large hiatal hernias, so should not be contraindicated in these patients and may be considered as a first-line surgical treatment for GERD. Thank you.